Hello friends, today we're going to discuss about Serotonin Syndrome. I am Dr. Suresh Padadmat, Professor of Psychiatry working at NIMANS, Bangalore. In this video, I'm going to discuss about what is Serotonin Syndrome, how to diagnose it, what is the etiology, what is the differential diagnosis, and management of Serotonin Syndrome. Serotonin Syndrome is also called as Serotonergic Syndrome and also serotonin toxicity. Serotonin syndrome is potentially a life-threatening, drug-induced toxidrome associated with increased serotonergic activity in both peripheral nervous system and also central nervous system. It is characterized by dose-relevant spectrum of clinical findings related to the level of free serotonin, that is 5-hydroxytryptamine, or 5-HT receptor activation. The activation receptors are basically 5-HT1A and 5-HT2A subtypes, which presents in the form of neuromuscular abnormalities, autonomic hyperactivity, and altered consciousness. These are the symptoms of Serotonergic syndrome. Serotonergic syndrome is precipitated by the simultaneous initiation of 2 or more serotonergic drugs. But it also can be seen after initiation of a single serotonergic drug in a patients who are susceptible for this syndrome. Further, it is very common when a combination of SSRI and monoamine oxidase inhibitors are given simultaneously. That means there are reasons for this serotonin syndrome to occur. Invariably, it is considered as iatrogenic in nature. Let's understand where are the serotonin available in human bodies. It is available both in the peripheral and also in the central nervous system. In the peripheral, serotonin is stored in the enterochromaffin cells of the gastrointestinal tract, and also it is seen in the platelet of the circulating in the blood. So 90% is in the periphery. The remaining 10% of serotonin is found in the cells of raphe nuclei located in the midbrain of the brainstem, that is from midbrain to the medulla. Let's look into the serotonergic pathways. If you understand the serotonergic pathway, you'll be able to understand the symptoms at the same time what are the remedial measures. If you look at this dorsal raphe nuclei, here both the rostral and the caudal raphe nuclei. If you look at the rostral raphe nuclei, it shows or it throws the projection across the central nervous system, that is to the prefrontal cortex, parietal, temporal, and also occipital. Further, it also throws into the cerebellum. The caudal raphe nuclei projects into the spinal cord. Both rostral and caudal are interconnected. That means serotonergic pathways are also present across the central nervous system. Serotonin syndrome encompasses a spectrum of disease. That is, symptoms are present. It is a combination of central nervous system and peripheral nervous system manifestation. There should be an exposure for serotonin reuptake inhibitors, and it is manifested in the combination of both signs and symptoms. Let's look into the Serotonergic syndrome symptoms. The symptoms are characterized by 3 important domains. One is mental status domain. Here, there will be altered consciousness, anxiety, restlessness, agitated delirium, and disorientation. If you look into the autonomic instability, you can see diaphoresis, that is sweating, tachycardia, hyperthermia, hypertension, vomiting, and diarrhea. Further, neuromuscular hyperactivity, tremor, myoclonus, hyperreflexia, and plantar reflex positive, also called as Babinski sign. In severe cases, you can see muscle rigidity, which is similar to neuroleptic malignant syndrome, and also myoclonus and hyperreflexia. In fatal cases, there will be hyperthermia, seizure, coma, and death. So these are the symptoms which are seen in Serotonergic syndrome. Let's look into the what are the signs. First and the foremost is hyperthermia, agitation, restlessness, akathisia. Further, it is characterized by slow, continuous horizontal eye movements, also called as ocular clonus. Mydriasis, dilated pupil, that means deep tendon reflexes are positive, tremor, and also inducible or spontaneous myoclonus is well known in Serotonergic syndrome. Muscle rigidity, bilateral Babinski sign positive, that is bilateral plantar reflex positive, dry mucous membrane, flushed skin, and diaphoresis. Increased bowel sounds. At the same time, you'll find nausea and vomiting in the patient. Let's see how to diagnose this serotonin syndrome. Of course, diagnosis is by thorough evaluation and taking a good history. First and the foremost, you need to understand the diagnosis is done by Hunter serotonin toxicity criteria. There are various criteria are available, but this has been accepted widely. This Hunter serotonin toxicity criteria talks about two important criteria. One is major criteria, that is presence of exposure to serotonergic symptom, that is serotonergic agents. That means recently there should be starting off an SSRI, or else increasing the dosage, or else the interaction of two SSRIs has been noted. That is the first major criteria. The minor criteria may be one of them. That is, along with the exposure to SSRI, there may be a spontaneous clonus, that is one, or else inducible clonus plus agitation or diaphoresis, or else ocular clonus and agitation, ocular clonus or inducible clonus, hypertonia, and increased temperature. The temperature should be more than 38 degrees centigrades. Further, it can also be tremor plus hyperreflexia. That means the top one is the major criteria. There are 5 minor criteria. Any one of them is there, we will consider as serotonin syndrome. How to diagnose this serotonin syndrome? First and the foremost, whether there is an exposure to SRI, that is serotonin reuptake inhibitor, is there an exposure? Yes or no? If it is yes, if it is associated with spontaneous clonus, that means we are going to have a positive serotonin syndrome. If it is no, look for other causes. If there is a spontaneous clonus is present, that means serotonin syndrome is positive. If there is no spontaneous clonus, but exposure to SRI is there, check for ocular clonus, agitation, diaphoresis, hypertonicity, and hyperreflexia. If it is present, then serotonin syndrome. If it is not there, then check for tremor and hyperreflexia. SSRI exposure, tremor, and hyperreflexia means definitely there is a serotonin syndrome. If it is not there, that means look for other causes. This is the simplest method of understanding Hunter syndrome, Hunter serotonin toxicity criteria. Let's look into what are the causes. The causes can be easily divided into 3 important things. One is overdose of serotonergic drugs. As you know, SSRIs are given especially in depression. And many of these patients with depression may also have suicidal ideas. They may take more medication than the prescription. So overdose can cause serotonergic syndrome. Further, second one is drug-drug interaction. That means there is a drug interaction between whenever there are two SRIs are combined. For example, fluoxetine and citalopram, if they are combined, the chances of serotonergic syndrome is high. Another drug interaction is monoamine oxidase in combination with SRI. Further, increased serotonin release which occurs in certain drugs, cocaine, amphetamine, or mirtazapine. Hence, combination of these can also lead to serotonin syndrome. Impairs serotonin reuptake. For example, tramadol, bupropion, SNRI, tricyclic antidepressant, ondansetron. They can, in combination with SRI, can trigger serotonin syndrome. Increased serotonin formation, especially tryptophan. If it is intake is there, there is a remote possibility. Further, certain drugs can increase the sensitivity of serotonin receptors. Then also this can occur. Let's look at in this diagram. In this diagram, you can see the top one is presynaptic neuron and the bottom one is postsynaptic neuron. In the presynaptic neuron, you can see number one. Here, there is an increased tryptophan intake. If there is an increased tryptophan intake in the food, then there is an increased formation of 5-HT. This can induce serotonin syndrome. Let's look into the second one. If along with the SSRI, that is serotonin reuptake inhibitors, monoamine oxidase inhibitors are given together, then there will be the enzymes inhibition occurs, monoamine oxidase inhibition occurs, and serotonin availability increases. Hence, there will be serotonin syndrome. Let's move into the third one. If there is simultaneous consumption of drugs along with SRI drugs, suppose a patient is abusing cocaine, methamphetamine, amphetamine along with SRI, then there will be increased 5-HT release. This also becomes susceptible for serotonin syndrome. Let's look into the fourth one. Increased 5-HT1A receptor activation. This is seen in some drugs, especially if SRI is given in combination with buspirone or else anti-migraine drugs like sumatriptan, elatriptan, rizatriptan, lithium or mirtazapine. This can cause again serotonin syndrome. Let's move into the fifth one. In the fifth, there will be 5-HT2A receptor inhibition, that is antagonist. Here, the commonest are second generation antipsychotics, quetiapine, risperidone, olanzapine, clozapine, and aripiprazole. And finally, serotonin reuptake inhibitors or else tricyclic antidepressant. Again, the blockage of this serotonin reuptake channels can increase the serotonin availability, hence serotonin syndrome. So these are the simplest way of understanding how the serotonin syndrome occurs. But however, one need to understand, many a time patients may be consuming complementary alternative medicine along with the SRIs. Hence, you need to educate the patient. Educate the patient that simultaneous intake of certain complementary alternative medicine such as St. John's wort along with serotonin reuptake inhibitors can trigger serotonin syndrome. Further, combination of SRI and monoamine oxidase inhibitors is a fertile soil for serotonin syndrome. Let's look into the differential diagnosis of serotonergic syndrome. This is the table of differential diagnosis. You can see there are 5 different rows. First one is serotonin syndrome. Second one, neuroleptic malignant syndrome. Third one is anticholinergic toxicity. And finally, the malignant hyperthermia. And if you look at the first column, the causative agent for serotonin syndrome is, of course, serotonergic drugs. For neuroleptic malignant syndrome, that is antipsychotics. Anticholinergic toxicity, the anticholinergic drugs. Malignant hyperthermia, which occurs immediately after inhalation of anesthetic drugs and muscle relaxants such as succinylcholine. So, depending upon the causative agent, you can differentiate the differential diagnosis from serotonin syndrome. If you look at the onset is sudden in malignant hyperthermia and anticholinergic toxicity and serotonin syndrome. Whereas in neuroleptic malignant syndrome, it is slower in onset. And others, the vital sign, pupils, mental state, almost similar in all the 4 categories. That is in serotonin syndrome, neuroleptic malignant syndrome, anticholinergic toxicity, and malignant hyperthermia. But however, the clinical features which differentiates from each other are very essential to remember. In serotonin syndrome, there will be hyperreflexia, tremor, myoclonus, clonus, and increased GA activity, which is the hallmark of serotonin syndrome. However, in neuroleptic malignant syndrome, led by rigidity, bradykinesia, and hypoactivity is common. Whereas in anticholinergic toxicity, normal muscle tone, dry flushed skin, hypoactive bowel sounds, urinary retention, hyperkinesis, myoclonus, and seizures can occur in anticholinergic toxicity. However, in malignant hyperthermia, the pathognomonic feature is recent inhalation of anesthetic drugs and depolarizing muscle relaxants such as succinylcholine. As soon as they take, within few minutes to hours, malignant hyperthermia sets in. It has rigor mortis like rigidity, hyporeflexia, hypoactive bowel sound, rising end-tidal carbon dioxide, mottled skin with flushing and cyanosis. So this is how we are going to differentiate between serotonin syndrome and NMS, anticholinergic toxicity, and malignant hyperthermia. Let's understand the severity rating of serotonin syndrome. Because before you start treating, you need to know what is the severity of this syndrome. There are three important categories have been placed. One is mild severity, moderate severity, and severe. If you look at the serotonin side effects is at the bottom. Brisk reflux, diarrhea and nausea, and insomnia. These are the commonest side effect. However, if there is mild serotonin syndrome, you are going to see hyperreflexia and inducible clonus in the neuromuscular area, tachycardia and hypertension in autonomic area, and in mental status, you will find anxiety. If the patient has moderate serotonin syndrome, you will see sustained clonus, myoclonus, opsoclonus, tremor in the neuromuscular domain, whereas in autonomic domain, you will find hyperthermia, mydriasis, flushing, and diaphoresis. And in mental status, agitation is common. And if you look at the severe serotonergic syndrome, you are going to see respiratory failure, rigidity, and in autonomic, severe hyperthermia, and low score on GCS, and confusion, and at times coma. So this is how you are going to rate the severity of serotonin syndrome. Let's look into the management of serotonergic syndrome. The management starts with the stopping the offending drugs or suspected offending drug. You need to stop it immediately. You have to admit the patient in ICU. This is for aggressive symptomatic management. Investigations such as biochemistry, RFT, LFT, hemogram, CT scan, if required MRI, CSF analysis, thyroid function test, investigation for fever, and serial creatinine phosphokinase need to be done. Further, electrolytes such as sodium, potassium, calcium, and phosphorus and manganese need to be done. Along with that, pulse, BP, respiratory rate, input and output chart every 6th hourly need to be documented. Supportive management in the form of adequate hydration, if required, nasogastric feeds, correct the electrolyte imbalance, treat the metabolic acidosis. Frequent change of posture is required to avoid bed sores, and also, especially in serotonin syndrome, there is a possibility of disseminated intravascular coagulation. Hence, sometimes you need to give administration of low-weight heparin to prevent pulmonary thromboembolism and disseminated intravascular coagulation. If the patient has agitation, especially in moderate serotonin syndrome, you can consider giving benzodiazepine such as lorazepam 1 mg to 2 mg or else diazepam 10 mg. 8th hourly can be given or else 12th hourly. Suppose the patient has autonomic instability, hypertension, esmolol can be considered. If the patient has hyperreflexia or hyperpyrexia, if the temperature is very high, you need to give water spray, ice packs, fan, AC, and also cooled crystalloids or cooling blankets need to be given so that hyperpyrexia can be reduced. However, paracetamol has a very few very least role to play here. Further, the best antidote is cyproheptadine. It is acts through a histamine 1 receptor antagonistic, but however, that antagonist which is very beneficial in serotonin syndrome is non-specific blockade of 5-HT1A, 5-HT2A, 5-HT2B, 2C, and 5-HT3, 5-HT6, and 5-HT7 receptor antagonism. Further, weak anticholinergic effects. If you look at this antagonism at the 5-HT1A, 2, C, and 5-HT3, 5-HT6, and 5-HT7 plays a crucial role. How to give this cyproheptadine? Cyproheptadine is available only oral medication. Either the patient has to swallow or else you need to crush the tablet and feed it through nasogastric tube. It is being given in two parts. One is loading dosage. The loading dosage of cyproheptadine is 12 mg orally or else crushed via nasogastric tube. Once you have given the loading dose, after that, every 2 hours you need to give 2 mg tablet to the patient until the patient clinically improves. That is how the serotonin syndrome is treated. But however, you need to know what is the prognosis. Prognosis is very favorable in serotonin syndrome, but you need to identify early, stop the offending drug, and treat the complication which is going to arise. But in most cases of serotonin syndrome, after stopping the offending drug within 24 hours, the symptoms starts improving. Only minority of the cases, the serotonin syndrome can last for 1 to 2 weeks. The prognosis is directly dependent upon the age of the patient, comorbid medical condition, overdosing, that is, if the patient has taken too many serotonin syndrome to kill himself, too many serotonin drugs, co-occurrence of neuroleptic malignant syndrome. That means if the patient is taking SSRI along with an antipsychotic and a monoamine oxidase, if they are all of them are there and the patient also develops NMS along with serotonin syndrome, can be difficult to treat. Long-acting drugs such as fluoxetine with other drugs can be potentially inducing serotonin syndrome. Further, in rare condition, paraneoplastic syndrome, carcinoid syndromes, if it is there, you need to identify that. Otherwise, the patient will have serotonin syndrome very often, and it will be very challenging for the psychiatrist to treat such cases. But however, you need to understand in some of the cases, especially in recurrent depressive disorder, chronic obsessive compulsive disorder, you need to give SRIs, that is serotonin reuptake inhibitors. In such a scenario, once the patient recovers from the serotonin syndrome, you may have to re-challenge with SRIs. How to do this? If your patient has developed serotonin syndrome and if you have treated him and he has recovered from the serotonin syndrome, you need to do the following things. You need to discuss with the patient and the patient family members regarding the need for serotonergic drugs and also the risk of recurrence of serotonin syndrome. The risk and benefit need to be weighed and the option should be given to the patient and the family members. And the patient will decide which one to choose, whether he will choose the same medication or else different class of medication he would like to take, or else even psychotherapy can be planned, especially if it is depression, OCD, or else any other anxiety disorder. I would prefer to give psychotherapy, but many a times the patient may not be ready to do psychotherapy. In such cases, you may have to change the class of antidepressant and give other classes like SNRI, venlafaxine may be there, or NASA, where you are going to give metrazapine. So, depending upon the offending drug, changing over to a different class of drug, or else offering psychotherapy will be the way to go ahead and treat after serotonin syndrome. To conclude, my dear friends, whenever you suspect serotonin syndrome in a patient who is on serotonin reuptake inhibitors, suspect it, stop the offending drug, start the supportive treatment by admitting the patient in ICU. Here, if the patient has severe serotonin syndrome, don't hesitate to start cyproheptadine. That is 12 mg loading dosage and every 2 hourly 2 milligram until the patient recovers. Serotonin syndrome generally has a good outcome. That means identify, treat early, and whenever you suspect, please stop the offending drug and treat early. That is the way to treat serotonin syndrome. Thank you very much for giving your valuable time. Stay safe.